NFLD is probably the most commonly used disorder in the world. And the prevalence of NFLD is rising with the rising prevalence of obesity and diabetes. Incidence of about 10 to 24% in the general population. But when you talk about the diabetes, about 55 to 75% of the diabetes have some form or some stage of NFLD. It will be also a leading cause of the hepatocellular carcinoma. Now, what is NFLD? It is nothing but it's a pathology which is the accumulation of fat in the liver, with or without inflammation and fibrosis, in absence of any secondary cause. And the alcohol intake should be less than 14 drinks per week in men and less than 7 drinks per week in women. Means the alcohol intake will be insignificant. NFLD is not a single disease, but it's a spectrum. Starting from the NFL to the NASH to the cirrhosis to the hepatocellular carcinoma. NFL is steatosis, then fat is more than 5% of the hepatocytes. Steatohepatitis means steatosis, then plus inflammation, plus hepatocellular injury, hepatocyte necrosis or inflammation. And cryptogenic cirrhosis, about which we discussed, the most important cause is NFLD, because by the time that we make the diagnosis of cryptogenic cirrhosis, the typical histological changes of the fat get lost. If you look at the natural history of NFLD, NFL, that is non-alcoholic fatty, the initial stage is usually benign and it remains stable in majority of the patient. But about 20 to 40% of the patient may progress to the NASH, that is non-alcoholic steatohepatitis, and which has a different prognosis because it may progress to the cryptogenic cirrhosis, or few of the patients may progress to hepatocellular carcinoma. There are certain established associations, there are certain risk factors which are associated with NFLD. The proven established association in diabetes, dyslipidemia, obesity, and metabolic syndrome. And there are certain factors which are emerging association, that is polycystic ovary syndrome, obstructive sleep apnea, hypogonadism, hypothyroidism, hypopatriotism, and pancreatic duodenal resection means rapid weight loss. And there are certain drugs which can be responsible for NFLD, that is steroid, antiretroviral drugs, calcium channel blockers, amiodarone, and some immunosuppressants. Let us come to the relation with the diabetes. We often discuss about the diabetes complications like microvascular complication and macrovascular complication, and we often forget this complication is a very important metabolic complication. As we all know, the basic underlying effect is insulin resistance, and this develops because of the genetic factor and environmental factor. We are genetically predisposed, and because of the excess consumption of calorie, sedentary lifestyle, we have the central obesity, visceral adiposity, and ultimately it gives rise to insulin resistance, which is responsible for the NFLD, which progresses to the NASH, then cirrhosis, then hepatocellular carcinoma. So underlying effect is metabolic syndrome, which is called as a common soil for the development of diabetes as well as NFLD. If you talk about the metabolic syndrome, there are three important complications: cardiovascular disease, diabetes, and NFLD. These both are also called as blended two, because the relationship between diabetes and NFLD is bidirectional. On the one hand, diabetes is an important factor for the presence of NFLD, for its progression, for its severity, and long-term mortality also. Diabetes increases the risk of development of hepatocellular carcinoma by 2 to 4 times. And on the other hand, NFLD has a three times increased risk of diabetes, and it's also a very important surrogate marker of the coronary artery disease in diabetic patients. Not only diabetes, see the slide, you can see the percentage of patients with NASH. If only hypertension is there, you will find about 30% of the patients have NASH. But once the diabetes is there, the percentage of NASH increases. And once there is both diabetes and hypertension, the percentage of NASH can go up to the 72%. So, diabetes plus hypertension acts as a fuel and fire for the NASH. In the case of NFLD, this is not the liver which is responsible for the mortality. Rather, this is the cardiovascular disease which is the leading cause of mortality in NASH patients. Because NFLD is associated with the increased intermediate thickness, higher caloric respiratory flux, impaired LV systolic function, and impaired energy metabolism. It's clear from the slide that you can see that the intermediate thickness increases as we move from the healthy control to the simple steatosis, then to the NASH. And this is the marker of atherosclerosis. NFL is also linked to the various vascular diseases, not only the cardiovascular disease. In the presence of NFL, the coronary vascular risk is much higher. Cerebral vascular disease risk also increases. Similarly, the peripheral vascular disease, you can see in the presence of NFL, the risk is much higher as compared when there is no NFL. And that's why if you compare the stenosis and NASH, you will find that the overall survival of the subject is less if the person has a NASH as compared to only the stenosis. When the fat plus inflammation, ballooning and fibrosis is there, the life expectancy decreases. What about the Indians? Are we more susceptible? The answer is yes. Indians develop diabetes at the younger age, at the lesser age, and suffer longer with the complications and die early. They have a high level of fasting insulin and more insulin resistance, higher dyslipidemia, glucose intolerance, thrombotic tendency, subclinical inflammation, and endothelial dysfunction, higher body fat, higher subcutaneous truncal fat, and intra-abdominal fat. This all makes us more prone to the development of NFLD like diabetes. Pathogenesis of NFLD. This theory was given by the Day and James, and this rather hypothesis is still acceptable to the majority. What Day and James described that there is two-hit hypothesis, that NFLD develops because the first hit, that is the dysregulation of the fatty acid metabolism, leading to the steatosis. And second hit is by the oxidative stress. What happens? That in the first hit, because of the increased breakdown of the adipose tissue, there will be increased free fatty acid formation. And these free fatty acids will be taken up by the liver. And on the other hand, we have the dietary free fatty acids. And this accumulates in the liver, leading to the high triglyceride content, leading to the fatty liver. So this is first hit because of the increase in insulin resistance. Second hit is because of incomplete free fatty acid oxidation, leading to the increased oxidative stress in the form of increased IL-1, IL-6, TNF. So the second hit is because of the increased oxidative stress, leading to the hepatocyte damage, inflammation, and necrosis, and ultimately going to the fibrosis. How to approach a case of NFLD? The most and foremost important thing is the awareness. We should always suspect, we should always target those patients who are having the clinical features of the metabolic syndrome, that is, who are having the best circumference more than 90 cm in the male and more than 80 in the female, more than 150 triglycerides, HDL less than 40 in the male or less than 50 in the female, blood pressure more than 130/85, fasting glucose more than 100 are a known diabetes, they are at risk of NFLD. As far as the clinical presentation is concerned, remember it's an asymptomatic disease in majority of the cases. It is most commonly revealed by the incidental finding, either on the ultrasound or asymptomatic elevation of the liver enzymes. Even if the symptoms are present, they are non-stressful, like fatigue. And there is no relation between the severity of the symptom and severity of the disease. And we should always rule out other causes of fatigue. Some patients may have right upper quadrant pain or discomfort, and on the examination you may get it better relief. But the most important point is to see for the associated morbid condition. As I told, the underlying defect is insulin resistance, and one should see for the marker of insulin resistance, that is, again, weakness, blackening in the axilla, the back of the neck. Similarly, skin tags, they demonstrate they are the feature of the insulin resistance, and one must see for the associated morbidity, that is, obesity, hypertension, cardiovascular disease, polycystic ovarian disease, and obstetric sleep apnea. These are the conditions which are often associated with the NFLD. Diagnosis. This is a very important point. The liver function test may be normal in 50% of the NFL patients. It may be normal in 20% of the NASH patients. And if the liver function test is abnormal, it is usually more than 2 to 5 times of the upper limit of the normal. If it is more than 10 times, suspect some other causes. AST-ALT ratio is very less than 1. ALP less frequently elevated. Serum ferritin may be elevated in 50% of the patients. Radiological, most commonly done, that is ultrasound, because the low cost is widely available. It's only positive when the steatosis is more than 30% of the liver. Sensitivity and specificity is good, but the sensitivity decreases that the person becomes obese. But remember, it cannot detect fibrosis. And the CT, MRI, these are the investigation. They don't add much to the ultrasound. Rather, they are expensive, and CT, they have low radiation. So ultrasound is the most commonly used investigation. But the only disadvantage is that it cannot differentiate between NFL and NASH. MRI spectroscopy, this is not so widely available. It's very expensive. But the only advantage is that it can quantify the triglyceride content or fat content of the liver. It's important to differentiate between NFL and NASH because it has a different prognosis. It may progress to the cirrhosis and hepatocellular carcinoma, but it's a completely benign condition. We have two options. Either we should go for the invasive staging or we should go for the non-invasive. No doubt, biopsy is the gold standard, but it's invasive. Non-invasive, as I told, ultrasound is there, but there is another important test that is fibroscan. It's also called as transient elastography. Fibroscan has the advantage that it is non-invasive. It can be done on the outpatient basis, bedside, and it gives a very important and good idea. Recently, it has been well validated that if the score is less than 1.4, it suggests absence of significant fibrosis. If it is more than 0.675, it predicts the presence of significant fibrosis. So at least we can have an idea whether there enough fibrosis is there or not. Biopsy is gold standard. It is the only method which can differentiate definitely between NFL and NASH. But risky. Bleeding, hemorrhage, even death has been reported, the 0.01%. And sampling error may be there. In the case of biopsy, you can see the sampling error, because some part of the liver may be involved, some may not. So the sampling error may be there. But the question is this, to whom should be subjected for the biopsy? Patients with NASH who are at increased risk of the advanced fibrosis, they should undergo biopsy. Or there you are suspecting some other competing etiology for the hepatic steatosis, then you can go for the biopsy. With the biopsy, infertility activity score can be seen, steatosis, inflammation, melanoma. But now, who are those patients who can progress to the NASH or fibrosis? There are certain markers, there are certain clinical predictors, like those who are having age more than 45, obesity, BMI more than 25, hyperglycemia, low albumin, low platelet, or ST-AT ratio more than 1. These are the patients who have the high risk to develop NASH and fibrosis in the future. So they may be considered for this gold standard investigation. But a simple thing to diagnose NFL and stages: first, identify whether the patient is having metabolic syndrome, or risk factor for NFLD, or raised liver enzymes are there. Second step, exclude alcohol or other HBV, HCV or autoimmune diseases. If no specific cause is found, imaging of the liver with ultrasound, RCT, MRI. If fatty liver is there, go for fibroscan. If fibroscan is normal, one should treat the fatty liver and follow it up. But if fibroscan is abnormal, predicting more fibrosis, you can go for the liver biopsy. If NASH comes, it should be treated accordingly. This is a simple for the diagnosis and for the management of the NASH. Now, question is, why treat patients with NFLD? This is largely a symptomatic condition because there is 1.7-fold increase in the standard mortality age and sex matched. So this must be treated. And the treatment is nothing but treatment of the underlying insulin resistance. There is no quick fix. Weight control, exercise, for reduction of weight, good diabetic control, good lipid control, these are the part of the medical. Diet lifestyle modification can both aspects of the metabolic syndrome, that is hypertension, insulin resistance, and dyslipidemia. Liver-directed pharmacotherapy is important only in those who are having the NASH or further. Coming to the diet, hypocaloric diet for all those who are obese or overweight. Low carbohydrate diet reduces the insulin resistance and triglyceride, it should be preferred. Diet should be high in low glycemic carbohydrate. High polyunsaturated fat means omega-3 fatty acid because there is improvement to be anti-inflammatory and favorable for the NFLD. There are certain weight loss agents like orlistat, which is like an inhibitor, and reduces the absorption of up to 30% of the triglyceride. Through weight loss, it results in the clinical, biochemical, and histological improvement. But limitation is diet and protein. Weight loss is the mainstay treatment of NFLD, and it should be done with both diet and exercise. One note of caution that weight loss must be gradual. If we try for the rapid weight loss that is more than 1.6 kg per week, it may promote or worsen NFLD. It may cause NASH and may result in a liver failure. So that weight loss should be gradual. And the loss of 3 to 5% of the weight is associated with the increased insulin sensitivity and steatosis, while weight loss of up to 10% is required for the histological changes, for the stoppage of the progression of the necrotic inflammation and fibrosis. It's very difficult to do because even less than 50% of the patient achieve necessary weight loss even under close supervision. Alcohol. We all know this fact that the moderate alcohol consumption is good. It is associated with the lower incidence of diabetes and CA. But as far as the question of NFLD is concerned, they should not be advised for this safer limit because they may cross to the unsafe limit also. Pharmacological therapies, not very effective because we have very few drugs. Insulin sensitizer, metformin, glucagon, lipid-lowering agents is statin in 5 days. Cytoprotective agents like UDCA, vitamin E, anti-TNF-alpha agents, anti-obesity drugs, and of course, surgical intervention that is bariatric surgery. There are the various drugs which have been tried in the various studies. That coming to the metformin, what we have the impression that metformin will be effective in case of NFLD, but most of the studies have shown that it is not very effective in the relieving the lowering the transaminases or steatosis or inflammation and fibrosis. The role is unclear. Some studies are favorable, some studies are unfavorable. But if the patient is diabetic, it must be used because metformin has been proven in various studies that it reduces the risk of hepatocellular carcinoma. Further trial and longer duration studies are needed to look for the histological improvement. These are the various studies have been done, but unequivocal results are there. Glitazones, that is the pioglitazone, PPAR agonist, it decreases the hepatic fatty acid level. It converts changes the pre-adipocyte to the insulin-sensitive adipocyte, means it causes the redissolution of fat from the visceral adipose tissue to the periphery. So it has a very good role, and it seems to be an effective treatment for the NASH, and various studies have shown that it can retard the progression of the fibrosis. But the problem was this, that after about 2 years when the drug was stopped, the histology again reverted to the same stage as it was there. So to treat steatohepatitis, it can be given in the biopsy-proven NASH, but the study is there in the non-diabetic and pre-cirrhotic condition where it can be used, but the long-term safety is a very important issue because it can cause great and CHF. Statins are safe and efficacious also. In those patients who are having the dyslipidemia with NFLD, of course this must be given because the hepatotoxicity is exceedingly rare. It should only be stopped when the LFT is more than 3 times of our limit of the normal. Vitamin E, 2 important studies are there. Virus and T-cause study, it has shown the good effect of the vitamin E after prolonged use, but the question is, it cannot be used for a very long time. The studies up to 96 weeks is available. It has shown good effect in both the biochemical and histological terms, but many meta-analyses and many studies have shown that the long-term usage may be associated with increased mortality, and of course the risk of prostate cancer is also there. As far as other therapies are concerned, infection-based therapies, preclinical studies are encouraging, but clinical data are very limited. Still no proven benefit. UDCA, very commonly used, but no study has shown its superiority over the placebo in either biochemical term or histological term. Pentoxifylline seems to be safe, but long-term placebo-controlled trial is needed, and it cannot be recommended. Losartan has been tried in 2 studies. Good results, but patient numbers are very less. Similarly, omega-3 unsaturated fatty acid, it can be used in those where the high triglyceride, but premature to recommend. This is a very new compound, that is obeticholic acid, a promising molecule. It activates nuclear hormone receptor, that is farnesoid X receptor, and this is the only drug which has shown to reverse fibrosis. Because this Flint trial, it has been shown that it improves the liver histology, 45%. as compared to the placebo. This is the first possibility reverse fibrosis. Adverse effect of there, it can increase little LDL and cholesterol, pruritus. Probiotics, few studies have shown the promising result, but it needs larger randomized control trial. A few words about the surgeon, who has the formula where there is doubt, take it out. Bariatric surgery. This is the greatest weight loss. Most sustained weight loss is seen with the bariatric surgery. And meta-analysis has shown that the improvement in steatosis is 91%, in steatohepatitis 91%, improvement in fibrosis in 65%, and complete NASH resolution in 69.5%. A very good mode of therapy only in those who have the high BMI, more than 35 with metabolic syndrome or more than 40 BMI. But the results are very good. Liver transplant, of course, it's predicted that in the future, presently it's the third cause of the liver transplant, but in the future it may be the first cause of liver transplant. In the last 3-4 slides, the study which I did in our institution, it was published in this year in the ADA, Boston. We compared the efficacy of 3 drugs, metformin, rosuvastatin, and pioglitazone on FMD. And this study was published this year. And what we saw that after the recruiting the patient and undergoing the various tests and ultrasonography, in the liver enzyme, both the metformin and pioglitazone cause the reduction of the liver enzyme, improvement of the liver enzyme, while the rosuvastatin caused a little bit rise of the liver enzyme, which was not significant. But as far as the NFLD score is there, rosuvastatin has the best effect, the greatest effect in improving the NFLD score as compared to the pioglitazone and metformin. So rosuvastatin was found to be better to the pioglitazone or metformin in reducing the NFLD score, while pioglitazone was found to be effective in improving the liver enzymes, while metformin, as observed in our study, has no added benefit in addition to the diet and lifestyle. Rosuvastatin has the maximum benefit, followed by pioglitazone. Ladies and gentlemen, in the last to summarize, I would say that the awareness of NFLD in general appears to be disappointingly low in the medical community. Insulin resistance and oxidative stress is the culprit for the causation of NFLD. Diabetes should always be assessed for the NFLD and vice versa. Ensure early diagnosis and multidirectional approach to prevent the occurrence of NASH, diabetes, and cardiovascular disease. Diet control, exercise, and weight loss is the cornerstone of therapy, and future research is definitely needed for the liver-targeted pharmacotherapy. Thank you very much for your patience.
Hi, sir. Hi, sir.
I request Dr. Soni to hand over the mementos for loving gratitude to the chairperson, Dr. G. Thank you, sir. Dr. Vandana Miller. Dr. Deol. Thank you. And we are going to now have a break, a lunch break for